Good morning. Welcome to the webinar. Thank you for your patience with getting started today as we worked through a few technical difficulties. Welcome to the webinar, Job Retention, Return to Work, and Chronic Illness. We're glad you're here. My name is Lisa Mighton, and I'll be moderating the webinar today. I'm with the Canadian Institute for the Relief of Pain and Disability. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships. As mentioned, I'm Lisa. I'll be moderating the webinar and handling the Q&A session. Our presenter today is Dr. Rob Gründemann. Dr. Rob Gründemann studied sociology at the University of Utrecht and gained his PhD at the University of Amsterdam on the subject of work disability. Dr. Gründemann works for a national research organization in the Netherlands called TNO and is a professor in the Research Center for Social Innovation of the HU University of Applied Sciences, Utrecht. He has been involved in almost 20 projects at the European level, recently in a project about healthy work for employees with chronic illness. Dr. Gründemann will now hand it over to you.
Okay, thank you, Lisa. Thank you for your introduction. And I would like to thank the Canadian Institute for the Relief of Pain and Disability to give me the opportunity to contribute to this webinar series. This webinar is about job retention and return to work of employees with chronic diseases. It is based on a European project financed by the European Union. And the European Network for Workplace Health Promotion has been responsible for the implementation of this project. It was the 9th initiative and took place between 2011 and 2013. So my information is related to the European context, but nevertheless, I have the opinion that the situation in Europe is also relevant for other countries, including Canada. On this sheet, you see the structure of my presentation. I will start with current developments which influence the position of workers with chronic diseases. These include policy reforms, new technologies, and the aging process. These developments create new opportunities for people with chronic diseases, but also ask for a paradigm shift. I will explain this later. Next, I will focus on sustainable employability. I will show you that this is more than occupational safety and health and human resource management, and should not only be directed at preventing risks, but also at promoting opportunities and skills. Then I will deal with definitions and preferences of chronic diseases and the impact of chronic illness on disability and on work. A chronic illness confronts workers with the need to alter their behavior and engage in activities that promote physical and psychological well-being. This rebalancing of the situation will be discussed under the topic of work-life balance and autonomy in the workplace. Related to this is the importance of self-management of workers with a chronic disease. The last part of my webinar will be targeted at more practical aspects on how to deal with chronic diseases at the workplace and criteria for success in vocational rehabilitation. I will finish with conclusions. New opportunities for workers with chronic diseases. In many countries of the European Union, sickness absence and return to work policies have been highlighted by new legislation the last decades. Policy changes in the fields of occupational health and safety, social security, and the labor market have been successful, to a certain extent, in reducing sickness absence and the number of disability benefit recipients. These developments are documented in a number of reports of the Organization for Economic Cooperation and Development, the OECD, on sickness, disability, and work. There is also a growing body of knowledge on evidence-based interventions and best practices. For example, with respect to musculoskeletal disorders, there is detailed evidence on best practices and a positive return on investment for employers, employees, and insurers. This is demonstrated in the article of Loisel and others on cost-benefit and cost-effectiveness of a disability prevention model for back pain management, and published in Occupational and Environmental Medicine in 2002. Another example is the publication of Waddell, Burton and Kendall from 2009 on vocational rehabilitation, under the title What Works, For Whom and Why. However, there is still much room for improvement. A study of sickness absence by my Dutch colleagues Kramer and Steenbeek in a Dutch working population showed that more than 20% of the sickness absence rate is avoidable. This study has been published in the Journal of Occupational Rehabilitation in 2010. Factors attributed to this unnecessary absence are related to the home situation, the workplace, occupational health care, and healthcare providers. One major reason for this is the lack of collaboration and coordination. Factors attributed to this unnecessary absence are related to the home situation, the workplace, occupational health care, and healthcare providers. One major reason for this is the lack of collaboration and coordination between the various professionals, institutions, and agencies. This lack of collaboration is common in many countries. A 2010 OECD study concluded that too many workers leave the labor market permanently due to health problems or disability, and too few people with reduced work capacity manage to remain in employment. Economic and labor market changes are increasingly proving an obstacle for people with health problems to return to work or stay in their job. Demographic change is currently leading to a rapid aging of the working population in many countries. This process is taking place all over the world, with exceptions for countries in Latin America, Africa, and Southwest Asia. In many countries, labor market shortages are on short or long term to be expected as a result of demographic developments. Both the aging working population and medical technology are responsible for a growing number of workers with chronic illnesses and disabilities active at the workplace. These workers will remain productive, or at least partly productive, and this productivity will be very valuable in view of projected labor market shortages in the future. Moreover, new technology will deeply influence the conditions behind the promotion of occupational safety and health in the workplace. The emerging psychosocial risks are the consequence of three developments. First, the growing use of ICT. Second, the expanding service sector. And three, new forms of work, such as telework, self-employment, flexible work, lean organization, etc. As a result of these developments, the opportunities for workers with chronic illnesses and disabilities will change. The rapidly changing world of work calls for renewed attention to be paid to the work and health of people with a chronic condition. This attention should not only focus on the current employability, but above all on the continued employability. This paradigm shift concerns the sustainable employability of workers with chronic illnesses and disabilities. Demographic challenges and rising costs of healthcare are forcing companies to focus more sharply on sustainable employability strategies. Postponing retirement, qualitative and quantitative mismatches in the labor market, and the need for an innovative and creative workforce are key issues. In developing these strategies, the potential of workers with disabilities and chronic illness should be emphasized. So being at work not only enhances the well-being of people with a chronic disease and give also income, but also contributes to national productivity and social cohesion. And from this point of view, rehabilitation costs are also investments in national productivity. Return to work and reintegration programs focus predominantly on the present job situation of the worker with health problems. This may not be sufficient for resolving problems in the workplace. Future career prospects may be equally important for workers with chronic illnesses and disabilities. Their disabilities are more or less permanent. Their optimal performance and productivity, as well as the prevention of future absenteeism, are dependent on the work content. In the post-industrial era, these contexts will become increasingly flexible and variable. As a result of flexibility in relation to tasks and responsibilities, as well as working hours, the workplace and contracts may be a barrier for disabled workers to continue working. But it could also provide better opportunities for work adjustments needed for participation. Skills development and learning at the workplace are probably even more important for the disabled workers than for workers in general. This means that human resource issues and occupational safety and health issues are becoming more and more interrelated. And this is reflected in the concept of sustainable employability, which is illustrated in this figure. In the ideal situation, company policy on sustainable employability is enabling a worker with a chronic condition to perform well and be motivated to undertake productive work in present and future jobs. This means that company policy is not only directed towards preventing risks, but also towards promoting opportunities and skills. This stresses the interrelatedness of occupational safety and health and human resource management with respect to sustainable employability. That's indicated on the left side of this figure, where you see 3 balls with safety, working conditions, vitality and health, and skills and competences. Actually, this may concern all company workers. For workers with disabilities in particular, the adaptation of the environment to their individual circumstances, including their home situation, is extremely important. And that's the yellow square at the top and also the yellow arrow in the middle of this figure. This calls for customized work redesign, job housing, training facilities, and career counseling. Again, the focus should be on the abilities and resources of the individual and not on the disabilities. Finally, the company's strategy should also include some sort of monitoring and evaluation to improve its policies and demonstrate the return on investment of its efforts in sustainable employability. And that is illustrated in the blue box at the bottom of this figure. Then we come to chronic illness and definitions and prevalences. Chronic conditions are defined by WHO as health problems requiring ongoing management for a period of years and cover a wide range of conditions that go beyond the conventional definition of chronic illness, such as heart disease, diabetes, and asthma. They also extend to cancer, mental disorders, musculoskeletal disorders, and communicable diseases such as HIV or hepatitis. Although in well-developed countries, most incapacitating chronic conditions occur after the age of 65, when most people are not working anymore. Anyway, their occurrence in the labor force populations is by no means rare. Due to the variety of chronic illnesses, it is not an easy task to determine the prevalence of the conditions in the labor force populations nationally or internationally. It is even more difficult to assess the impact they have on employment status. However, population surveys, which rely on self-reported conditions, are an accepted way to record health status and disability. In recent European Union statistics on income and living conditions, respondents were asked whether they suffered from any chronic, long-standing illness or condition, health problem, and whether they experienced limitations in their daily activities and work for 6 months or more due to health problems. And in total, 23.5% of the working age population in the European Union reported chronic conditions. That is 1 in 4 workers. A slightly smaller group of 90% of the employed persons report long-standing health problems. Over 80% of the long-standing problems were considered not to be work-related. There were also large differences between the countries in relation to self-reported health. So it can be presumed that the answers at least partly reflect cultural differences in health perception between the European countries which were involved in this study. The International Classification of Functioning Disability and Health, the ICF, recognized that every human being can experience a decrease in health status and may thereby experience some degree of disability. In other words, this is not something which only happens to a minority of people. The ICF model distinguishes 3 main elements. First, a health condition, which may lead to, second, an impairment in function, which may in turn lead to 3, disability within an unsupportive environment. Disability is therefore due to an interaction between these 3 elements and not solely function of a health condition in itself. An impairment refers to a physiological problem, for example, difficulties in seeing, fatigue, or reduced muscle power. Disability concerns the daily problems which arise due to these impairments in the context of the daily environment. Thus, not only the health condition itself, but also the environment may influence the extent of the disability. It is important to note that most people with defined impairments, such as visual impairment or paralysis, do not consider themselves to be ill or to have an illness. The ICF thus mainstreams the experience of disability and recognizes it as a universal human experience. And by shifting the focus from cause to impact, it places diverse health conditions on an equal level, takes into account the social aspects of disability. Moreover, it is not only focused on disabilities, but also on abilities and resources, which are important for the daily performance of people with a chronic condition. The work and family environments are, of course, essential context for workers with a chronic condition. If you want to make a correct assessment of the situation, And to optimize participation, we should not only take into account the working conditions and the workload of the worker with chronic illness, but also family obligations and support. As mentioned earlier, the list of chronic conditions and disabilities is very diverse, and since the progression of an illness can vary considerably, the impact of illness is highly individualized at each point in time. The common element is that all of these conditions require a complex response, including within the work environment, over an extended period of time. This involves coordinated inputs from a wide range of health and other professionals. But it also includes access to essential medicines and monitoring systems. All of these need to be optimally embedded within a system that promotes patient empowerment. Unfortunately, healthcare is still largely based on an acute occasional model of care that is ill-equipped to meet the requirements of people with chronic health problems. Moreover, occupational health care and health promotion in companies are not enough directed at the needs of workers with a chronic condition. The communication between the various parties is often poor. I will come back on this topic later. Now I will go on to the impact of disabilities and chronic illness on work. The variation in the impact of chronic illness on work is as great as the diversity of chronic conditions. However, some common elements can be identified, because in many cases communications between peers and line management on this topic is covered. One should be on the lookout for the following consequences. You have to look at the behavior of the people with the chronic conditions at work. And look, these are some of the things you can notice and which should ring a bell. Things like people who are feeling alone, who have a lack of understanding with colleagues, people who have an unexpected low performance, have frequent spells of absenteeism, or much more things which are on this overhead. Fatigue is a common complaint and sometimes difficult to assess. Another major characteristics, apart from being chronic, are the often unpredictable prognosis and the variability in the course of the disease. There's often not much to see from the outside, for example in the case of pain or fatigue. It is always important to consider the consequence for occupational safety and health. Job adjustments should be tailor-made, and some jobs may even be contraindicated by some diseases. COPD, for example, and chronic hepatitis, or eczema are examples of illnesses which would make some jobs unfeasible. Although the impact-centered approach of the ICF is essential in all return-to-work policies for workers with a chronic condition, the cause of the illness matters to the assessment of specific impairments and the prognosis. It also matters because many countries and systems make a distinction between conditions caused by occupational activities and those which are not. In the case of occupational disease and accidents, the employer or the insurance system acknowledges responsibility for vocational rehabilitation. In general, more resources are available to adjust workplaces or offer re-education. However, as stated before, over 80% of long-standing problems are considered to be not work-related. When an illness or disability has no clear causal relationship with the job, for example by a heart failure or diabetes, employees and colleagues are often more unwilling to become involved. There is a tendency to consider such illness a private matter, and the worker may be hesitant to discuss the consequences of the illness with their employer. And certainly this will hinder any appropriate job adjustment and sustainable employability. Work-life balance and autonomy in the workplace. As mentioned before, chronic illness confronts workers with the need to alter their behavior and engage in activities that promote physical and psychological well-being. In this rebalancing of the situation, job requirements and resources, as well as private and family requirements and resources, should be equally taken into account. And this figure illustrates this process. Optimal performance on the job is very much dependent on this rebalancing act. Appropriate levels of job control and autonomy are of the greatest importance if a worker with a chronic illness is to realize adequate job performance. This figure also contains on the left side the job demands control model of Karasek, and in the middle demands and support of the family. Naturally, interventions have to proceed in close cooperation with management and peers. Vocational guidance and mutual trust between employer and employees are also important, and this should finally lead to sustainable employability and good job performance, productivity, and vitality and well-being of the worker with a chronic disease. Many failures in the reintegration process of chronically ill people are caused by a lack of coordination between the parties involved. The key actor in this coordination issue should be the worker. Several reports and studies mention the importance of self-management when organizing the active participation of people with chronic illness in a treatment. There is an increasing recognition that reduced risk and improved outcomes cannot depend solely on the actions of health or other professionals. They are also depending on the individual's own actions. In healthcare, various approaches and methods have been developed to support the self-management by individuals. For example, in terms of assessing their own health risks and health problems, and in finding and applying effective approaches and methods. Self-management support includes three elements. First, education and training of chronically ill people. Second, collaborative use of a wide range of behavioral change techniques to foster lifestyle change. And thirdly, adaptation of health-promoting behaviors and skill developments across a range of chronic conditions. Well-known support include shared decision-making tools, which are usually designed for specific illness categories. These self-management support tools are not particularly intended to support the sustainable employability of workers with chronic illness within the workplace. However, there are many ways to make these shared decision-making tools applicable to the work situation. This can be done by including work experts in self-management protocols and by involving line managers and health and safety professionals in self-management processes. In this way, workers with a chronic illness have the opportunity to become the crucial point between the worlds of healthcare and work. A well-informed worker can facilitate communication between health professionals and stakeholders on the employer side, such as company doctors, HR managers, line managers, and colleagues. How can a worker with a chronic disease and the main actors around him or her effectively deal with complex illness? ANACT has developed a practical guide which may support self-management by the worker. ANACT is the French National Agency for the Improvement of Working Conditions. It's a public institution managed by a three-party council, including employers, employees, and Ministry of Labour. ANACT helps business to improve both the performance of the organization and the working conditions of their staff. On the next slide, I will present some examples of this kind. For more information, I will refer you to the website, which is at the bottom of this slide, the www.maladiechroniquetravail.eu. Unfortunately, most information on this site is in French, but I know there are a lot of people in Canada too who can easily read French, so I should advise you to go to this site. This slide is about how to deal with actors. The first observation on the left side is a situation which occurs often. Many different actors are involved in the guidance of an intervention, and the recommendation on the right side is to list the actors and to determine roles in different settings. The second example is about conflicting concepts and confidentiality which interfere communication. This situation can be solved by a multidisciplinary approach. The case manager is responsible for the process, the occupational doctor for appropriate working conditions, and the worker fulfilling a central role in the communication. This slide is about interventions. The first observation is about a frequently changing situation as a result of variations in the illness. The recommendation is about introducing pilot periods with clear targets and monitoring and evaluation. As a result, targets could be adjusted when the worker is not able to achieve the goals. The second observation is related to compensation actions of the worker when targets are not met during working hours. This can be solved by a proper assessment of the vocational situation and by offering solutions as teleworking and/or flexible working hours. The last examples are about long-term processes. First is in line with the observation on interventions. Again, variability in job performances as a result of variations in the illness. The recommendation is directed at the introduction of monitoring and evaluation of the situation and the performance. The last observation is on the long-term effects of the illness on the career of the worker. The recommendation is focused on career counseling and training and education. Also, reference is made to potential financial support from Social Security. You can see these are all very practical recommendations and can be used in common situations related to the employment of workers with a chronic disease. The most important issue for the company and the worker is to adopt a methodical stepwise approach, which secures open communication in the workplace between the worker, the management, and the peers. It involves all relevant actors and aims to establish a common frame of reference and a clear case management. Is flexible and open to readjustment and periodic evaluation, and finally is embedded in general health promotion policies of the company. Well, the focus in this lecture has been on the company practice. I would like to end with an emphasis on the providers of vocational rehabilitation. These stakeholders also play an important role in the support of workers with disabilities and chronic illnesses. Case studies and other literature have already provided much information on good practice in vocational rehabilitation and return to work programs. Using evidence-based empirical research, we can draw up 7 criteria for success. First, key features of the rehabilitation program are multidisciplinarity, early involvement of actors in the work environment, a high standard of assessment, there's a clear distinction between the treatment and intervention phases, and time-contingent case management customized to individual needs. Second, well-educated cooperative team, which includes continuity in training of new team members, motivated by continuous feedback on the results of their actions. 3, a transparent organization, which include management, process, and logistics. 4, commitment of local stakeholders, clear channels of referrals, creating awareness of each other's practice. 5, strengthening commitment and self-management of clients, empowerment, shared decision-making, etc. 6, continuous critical evaluation of the program itself by the team on process and outcome, for example, by users, clients, employees, and monitoring of themselves. And 7, institutional breakthroughs in financing interventions and cooperation between HR, OSH, and public health care. I would like to summarize the main conclusions from this webinar. Policy changes have been successful in reducing sickness, absence, and disability, but there is still much room for improvement through institutional reform and an everyday practice. Factors attributed to this unnecessary absence are related to the home situation, the workplace, occupational health care, and healthcare providers. And one major reason for this is the lack of collaboration and coordination between the various professionals, institutions, and agencies. Both the aging working population and medical technology are responsible for a growing number of workers with chronic illnesses and disabilities active at the workplace. Being at work not only enhances the well-being and income of people with chronic diseases, but also contributes to national productivity and social cohesion. The rapidly changing world of work calls for renewed attention to be paid to the work and health of people with a chronic condition, and for a focus on the continued employability. The list of chronic conditions and disability is very diverse, and since the progression of an illness can vary considerably, the impact of illness is highly individualized at each point in time. And the work and family environments are essential social contexts for workers with a chronic condition. This is the first part of the summary. Now the second part. Chronic illnesses are quite common among the working population and will be more common in the near future. But over 80% of the long-standing problems are considered not to be work-related. The variation in the impact of a chronic illness on work is as great as the diversity of chronic conditions. More attention should be on the abilities and resources of chronically ill workers, because these are important for the daily performance at work. And many failures in the reintegration process of chronically ill people are caused by a lack of coordination between the parties involved. The worker should be the key factor in this coordination and communication. The most important issue for the company and the chronically ill worker in dealing with chronic illness at the workplace is to use a methodical stepwise approach. Strengthening commitment and self-management of clients, empowerment and shared decision-making are criteria for success in vocational rehabilitation and return to work process. Finally, I hope I've showed you that sustainable employability of workers with chronic condition is more than occupational safety and health and human resource management. But the variation in the impact of work is as great as the diversity of chronic conditions. But the most important issue for the company and the worker is to adopt methodological, stepwise approach. How a worker with a chronic disease and the main actors around him or her can effectively deal with this complex illness. And finally, the self-management of people with a chronic illness is the key factor in the reintegration process.
Thank you, Dr. Gründemann. Thank you so much for joining us. We invite you to submit questions for Dr. Gründemann. You can put them in the chat box, and I will relay those questions to him. One question from Monica, if you don't mind, just asked if you could repeat the 3 components of self-management. Dr. Gründemann.
Yes. I will look in one moment. The 3 components are education and training of chronically ill people, collaborative use of a wide range of behavioral change techniques to foster lifestyle change, and thirdly, adaptation of health-promoting behaviors and skills development across a range of chronic conditions.